But first I will give the word to Angelique Belguide from Philips to give some introduction. So, floor is yours, Angelique. Welcome.
Thank you very much, Bo. Welcome, everyone. It is a true honor to be standing here and speaking before you. Indeed, a landmark event where we'll discuss one of the most important developments in the recent history of medicine. And I'm really happy to be giving you a bit of an outline of why we should care about this. I realize some of you are from governments, policymakers. You've got a great responsibility on your shoulders to make wise investment decisions for your people, for your citizens, and that is what we will be speaking about today. So, I want to start with a picture, a historic picture of Alexander Fleming. He was the inventor of penicillin a century ago. And I think it's an important comparison because this was really the big healthcare leap that was done 100 years ago to treat patients with pneumonia through antibiotics. And we really are at the same leap of healthcare improvements today. And this is really what we are going to be speaking about because we know strokes are an enormous burden. We will speak about that. We also have treatments that are very effective. And we'll also talk about what happens if you invest in better stroke care for your country. So let's first talk about strokes. Why are they such an enormous burden? It really has to go back to the brain. The brain is the organ that defines us. It defines how we talk, how we walk, how we think, how we feel. It is defining our being. It defines our identity. So if you have a stroke, you no longer have the abilities, in some cases, to walk, to talk. Your emotions change, your personality changes. And that is major. That is major for a person. It's major for their family members. And that is why it's so important to realize that. And I'll show you a short video, and I'm honored that Stacy is with us today. Stacy, if you just wave your hands. I'll show you a video of Stacy, my friend, who was 46 when she suffered a stroke. And I think the way you described it, Stacy, on what the impact was for you, made a huge impact on me, and I think it's worth to show it to you.
I'm Stacy. I'm a writer, a mother of 3, a wife, and a stroke survivor. When we reached the emergency room, it was a bit foggy. They kept asking me my children's names, and I had my first insecure moment because I couldn't remember them. And I was freaking out a little bit. When I awoke from my surgery, I was reduced to an infant. I couldn't walk, talk, or feed myself.
I think almost 100 times. And every time it gives me goosebumps, and I think it's really important to realize what a stroke does to a person. Thank you, Stacy. Because Stacy was one of the lucky ones. There are so many patients that actually are not lucky, that end up in a wheelchair, that end up paralyzed, that end up not being able to talk. And just to give you a statistic here, 2/3 of stroke patients are in the working age. It's not only elderly people that have a stroke. And so it's a personal burden, it's a family burden, but it is also a leading cause of disability and the second leading cause of death. And then talking about the costs that are associated with it. In 2017, and this is from the Lancet Neurology publication last year, 2017, $912 billion were basically the cost of stroke, and that is expected to only grow almost double by 2050 to be an annual cost of $1.5 trillion, which is a huge amount. But we have effective treatments. 2015 was the landmark moment that was basically another revolution in stroke care when thrombectomy showed that pulling out the clot with a catheter, what you're seeing on this illustration, can reopen the vessels, and with that, it has the potential to reverse the impact of a stroke. And that was monumental, that change of this clinical data that came out. 5 trials at the time were published in the same New England Journal of Medicine issue, and that changed the world of stroke forever. And the conclusion of all of those papers were that stroke thrombectomy strongly benefits patients with severe ischemic stroke. Now, 3 years after, this is what the image of, as an example, Europe looked like, and it doesn't look very different in other parts of the world. On average, the number of patients that have ischemic stroke that end up getting this treatment was 1.9%. And the number of patients, just to give you another statistic, of patients that actually receive intravenous thrombolysis was 7%, and that's actually 30 years after the evidence that came out for it. So a lot of work to do. And just to give you also a glance of what does that mean in terms of the global average, on every 20 patients that have a stroke, only 1 gets stroke treatment, and I'm speaking stroke treatment in general, 1. If comparing it with, for instance, a disease like cancer, if there would just be 5% of patients that have cancer that would get treatment, it would cause an international outcry. So we really feel that it's important to get attention for this. Putting it into perspective, the effectiveness of mechanical thrombectomy, I show you here the number needed to treat to prevent 1 additional bad outcome of patients. And I'm showing you a couple of examples of other disease states that, to give an illustration of the impact of this treatment, of this new treatment. So when we look at lung cancer screening programs, the number needed to treat, so how many patients do you need to scan before you find 1 patient that has cancer, is 219. If we look at the cardiac space, coronary interventions for acute coronary syndrome, the number needed to treat to prevent rehospitalization in 6 to 12 months is 15. Alexander Fleming with antibiotics for pneumonia, number needed to treat 6. The number needed to treat for stroke intervention to reduce disability based on those 2015 trials was 2.6 to reduce disability. So a major leap forward. So what happens if you invest? Is it worth the investment? Is there a return on investment? Well, there have been extensive clinical studies, and I'm just showing 3 here, but in Europe, in the US, and recently also in Brazil, to show that not only in high-income countries, but also in middle-income countries, it's worth to invest in stroke care, and there's a cost benefit to do so, and there's been extensive evidence to show this. And just a very specific example of one country, and here we created a simulation of Germany as a model. If we were to increase the number of thrombectomies in Germany from 5 to 20%, the cost would increase, the direct acute costs, by 37 million. However, the savings of mid and long-term costs would be 118 million. So net, there would be a benefit of treating more patients, and that is very unusual for the medical field. Another publication that just came out in The Guardian a couple of weeks ago that indicate indeed the expectation of UK to rise the number of stroke victims really will be rising tremendously, but also stating similar numbers as we did the simulation for Germany on. If thrombectomy would be universally available in the UK, that would lead to a 73 million pounds each year of savings, and also would allow 1,600 more stroke survivors to be independent. So with these data, I'll leave you with the address, the opening address, and what you see here is a QR code of a new World Stroke Organization policy paper that we are preparing and that you can request to get sent to you. I thank you for your attention.
Angelique, thank you very much for giving this background, and we will now proceed. Proceed with the first panel, which will give you some more insights on what is the current status, what are the main topics, how do we proceed from here from a scientific point of view. So I welcome the 4 panelists up now to the podium, and Taskin, you take the first chair here, and Carlos, the next one. Beam number 3, and we have Carla for the 4th one, and here is Carla. So welcome everybody, and we have an expert panel of speakers here. Let me introduce to you Taskin Khan, who is at the NCD department at the WHO, medical officer and the contact person for the World Stroke Organization. And next we have Carlos Molina from Spain, one of the pioneers in the stroke field, one of the pioneers in the thrombectomy field, with one of those seminal trials. He was responsible for one of them. And coming to the next person, Wim van Swan from the Netherlands, from another landmark study, actually the very first one, and you'll be doing so very much in this field. And finally, Carla from Philips, senior medical officer with a medical background and very knowledgeable in this field. So let me start first to ask you, Taskin, that what are the main activities that WHO is doing in the stroke field? What is your perspective on what you are doing and what you are promoting? Taskin.
Thank you so much, Bo. And thank you to everyone here who are supporting such an important cause. I think, maybe I'll take a step back and just explain what the WHO does, because I find that some people don't know how exactly the WHO works. So basically, we're a secretariat. And it's actually member states and countries that drive our agenda and that drive the priority setting, but also the global health agenda, I would say. And that's what we're all here for now. We all know the World Health Assembly is where it all happens, where countries deliberate, where they decide, and where they approve of what the Secretariat will do. And so largely we work at a policy level and we try and influence policies. But here at the headquarters, what we try and do is actually develop norms and standards and develop guidance for which countries can look to and also can adapt. And one of the things that we look at in the field of cardiovascular diseases, because for the WHO, cardiovascular diseases include both heart diseases and stroke. So let me make it very clear that it's CVDs and stroke. And what we're looking at the care continuum, actually. So we're looking at prevention, we're looking at diagnosis and acute treatment, we're looking at long-term care or chronic care, and we also look at rehabilitation. And across the spectrum, there's various things that we do. But one of the most important documents, I think, that the WHO has in the area is something called the Appendix 3. Not a very nice name, Appendix 3, but it's actually an addendum to the Global Action Plan on Non-Communicable Diseases. And so there's a few interventions, actually, that lend itself towards stroke. And that starts with something called the pharmacological treatment of hypertension using one of the 3 classes of drugs. We've got acute ischemic stroke treatment, and that's really intravenous thrombolytic therapy and mechanical thrombectomy, secondary prevention of ischemic stroke, administration of low-dose aspirin following a stroke event, and then comprehensive stroke unit care. And these 7 interventions make up what we call the cost-effective interventions that countries should use to determine their universal health benefit packages. The organization is on a big drive to promote universal healthcare coverage. And one of the ways that we can do this is by embedding cardiovascular diseases and stroke into that care. We all know that cardiovascular diseases, including stroke, are the leading cause of death globally. We say it again and again and again. But what we also need to recognize is that in order to achieve SDG 3.4, and we're not doing well on the SDG health goals, but we're certainly quite far behind on the NCD one on premature mortality. If you don't address ischemic heart disease and stroke, you actually cannot attain SDG 3.4, regardless of all the other combined interventions. There was a very good Lancet countdown paper that showed that if you invest in hypertension treatment, hypertension being the most important risk factor for stroke, and in secondary prevention, which is care for people who've had a stroke or a heart attack, those 2 interventions alone will be the bulk of how countries actually make it towards SDG 3.4. I think we've got an insurmountable amount of evidence that shows us why we should be working in this area. The thing is, public health, population health has traditionally been around communicable diseases. It's been around health security, and rightfully so. And I think, Angelique, you actually showed that antibiotics changed the tide. It really changed our perspective on public health. And we need that similar approach when it comes to things like heart disease and stroke, because not everything lends itself towards a population approach, but certainly hypertension, ischemic heart disease, and stroke lend itself towards that simply because of the numbers, the prevalence, the economic burden on countries. And let's be clear, there's no global fund on NCDs. There's no global fund for cardiovascular diseases. It all goes back to what countries can invest in, what they can manage, and how they can lead to more equitable care. And we know that there are certain cost-effective interventions that can be driven from the public health perspective, and we just need to go out there and do it now.
Thank you very much for very wise words, Taskin. And let me take this opportunity to thank you also for being such a strong spokesperson on prevention of stroke and what can be done by hypertension control, and also supporting with the build-up of services, been very strong promoting of the Appendix 3, which is so very important to us, because this is a document of the highest level that recommends what should the member states do, and it's a very important document, really. Let me also say just one word of clarification, because I was involved with ICD-11 and the classification. The term cardiovascular means heart disease and stroke and other vascular diseases. Very often, this is by Wikipedia definition, but very often is misinterpreted as just heart disease. And that's very important for stroke. That's to say that stroke is part of this is part of this package. It should not be forgotten. It has been forgotten for many years, but now this is over. So now over to you, Carlos. You're one of the pioneers when it comes to the development of stroke services, and please tell us, how should we build up the acute stroke services? What is needed in the hospital and pre-hospital, and what are the basic elements that we need to look after? Carlos.
Thanks, Bob. So as you know, stroke is a complex process of care. It's very complex, involve different agents, as was mentioned before by the skin. So we have not only the primary prevention, we have the pre-hospital, which is critical to ensure the access to treatment, not only for ischemic stroke, for hemorrhagic stroke as well. And also the acute management, treatment, and also the life after stroke, the always forgotten part of stroke, life after stroke, rehabilitation, and how we accompany the patient. So it's a very complex process of care, different agents that need a very strong and well-orchestrated infrastructure. So the three main elements of this infrastructure is triage and diagnosis, rapid triage and diagnosis. We need CT scans. We need resources in the pre-hospital setting. We need not only mobile stroke units, but also other methods that are scalable at the scale that we can use to identify not only ischemic stroke at those patients who are going to be candidates for mechanical thrombectomy, but also ICH patients. Recently at the ESOC, so there was a paper of the Interact 4 showing that the early diagnosis of ICH is critical to improve outcome not only for thrombolytics or reperfusion, is for lowering blood pressure. So all these strategies have to be in place. It's not expensive, and we can just organize ourselves. This is the pre-hospital part. So once the patient arrives to the hospital, we need to have a CT scan in the hospital. Still in the world, there are hospitals that receive stroke patients without diagnostic capabilities. So we will never imagine to send a patient with a pneumonia to a hospital without RX for diagnosis. We need a CT scan. So this is the purpose, and the Angels Initiative work a lot on this, on improving the workflows to the CT scan. This initial concept of direct to CT scan now is a standard of care. So patients has to be transferred directly to the CT scan for treatment for IV TPA. And the case it's an ICH, and intracranial hemorrhage is not thrombolytics, so we need to lower the blood pressure because we can ensure we can improve outcome that way. So also we need to centralize and identify comprehensive stroke centers for mechanical thrombectomy. This is an essential part for the more severe stroke patients that Anjali clearly demonstrated and showed how they improve this treatment dramatically improves clinical outcomes in the more severe stroke, ischemic stroke patients. But we have also ICH, and both ischemic and hemorrhagic strokes, they benefit for stroke unit care. This is an essential part, the core of the management of stroke patients. This is a real need to implement stroke units. And then we need to smooth the transition from hospitalization to post-hospital care. So we are always focused on the clinical follow-up, but sometimes rehabilitation can be implemented, but we forget the social support. Our stroke survivors, they need social support, and we need to advance the needs. And we need to not to follow up to avoid recurrence, just to improve the quality of life of stroke survivors. So in a sense, there are a lot of achievements over the last years, especially in the last decade. See, the Angels Initiative work really hard on that. And there are examples in South America in the last 5 years, the number of certified stroke units increased dramatically. And also they managed to organize the pre-hospital setting to speed up the process to TPA and mechanical thrombectomy. And it's amazing how the main driver for stroke treatment was TPA. So we start with TPA and everything follows. So it's the main driver for even for ICH. If we implement a good pre-notification system, stroke code activation is good for TPA, for mechanical thrombectomy, for ICH patients. All they benefit for this improvement in the system of care. So there are different examples around the world, not only in South America, in South Africa, and also in Asia. So this initiative is a global initiative that is really strong and has changed the life of millions of stroke survivors.
This is wonderful, and this is one of the basic principles that stroke unit therapy for all hospitals who admit acute stroke patient should have a stroke unit. This is real basis. Without a stroke unit, you cannot do it. And still we see these numbers that there is not more in Europe, for instance, half of the patients that are treated in stroke units. In other parts of the world is even less. So what are the barriers? Why don't we see a move in this field?
The main barrier is not technological.
No.
Resources is a barrier for sure, but I think it's communication. We need to create this interconnected ecosystem of professionals, the administration, physicians, healthcare providers, patients. We always forget the patients. We put the patient at the end when it has to be at the very beginning of all this process. And we need to customize our solutions on the local basis. So there is not one rule fits all. So we need to just work at the local level. We have examples, we have resources also, external resources, internal resources for sure. And what Taskin mentioned about the investment is really, I'm sorry, ridiculous compared to the burden of a stroke globally. So we need all together to be in the same front. So to make this happen, to have the investment and resources in a stroke, not only for public funding, but also for private fundings. So this is the main limitation. Yeah. And I think now, and this is an example here in this audience, so we have the support from the administration and governments. They are really involved, they care about the problem. So we are here just to connect and to give some solutions in anything we can help. That's why we are here.
Yeah. So this is absolutely achievable to arrive at that level. So we will proceed now with one of the recent major advances here, which is thrombectomy. And this is historical, really. So Wim, you were one of the pioneers in this field, the very first study to show a really positive effect. Tell us what is thrombectomy, how many patients could be suitable for acute stroke therapies and for thrombectomy. Please expand on this.
Yes, thank you, Bo. Yes, we were, well, in a small country, the Netherlands, where we still have around 40,000 stroke patients per year. So that can be minor stroke, but also many major strokes. And in the past, we've seen that those patients did not get proper treatment. With the thrombolytics already 30 years ago proven to be effective, we could treat many of those patients, but the effect, especially in the most severe stroke, was minimal. So we saw those people suffering in my small country. Then we did this study, this trial, where we finally showed that this thrombectomy, getting the clot out with a device, was successful. And you should have seen us cheering when we finally found out that we had a treatment. And the treatment was so effective that Angelique showed us that it is really effective. We save many patients, and we do not save lives that much. Mortality, okay, we save little mortality, but we keep patients out of rehabilitation centers. We keep patients in many countries where there are no rehabilitation centers where they go. They are cared by their family, but it's a huge burden on the family, it's a huge burden on the community. And with this effective treatment, those most severe strokes can be saved. It's achievable, it's feasible, it's possible if you invest in it. And you can say, okay, in your Western country, in the Netherlands, you can invest in it because you have the money. But we can show you that even in low or middle income countries, the investment is definitely worth the investment. Finally, you will gain your money back. Finally, the investment saves lives, but saves more burdens of family, of communities, and finally, it will save money as well. In Brazil, they have shown it. It is cost-effective in Brazil. It is cost-effective in most of the European countries. And definitely, with those 40,000 stroke patients in the Netherlands on a population of 18 million, you can see how huge the burden is and how many patients finally you can save. We were talking about how many patients can you treat with endovascular treatment. Well, in my region, in my hospital region, we serve about 1 million. And over the past years, we treated 250 patients with thrombectomy. So on a population of 1 million, you can reach, I think we are on a ceiling more or less, 250 patients per year. But those are the most severe strokes. Those are the strokes that did not benefit from intravenous treatment, from thrombolytics. Those are the patients that finally end up in rehabilitation centers, need 24/7 care afterwards. And if you treat them, well, you can see it stays here. You see a bright, shining person. That is what can happen if we implement this treatment. So it's worth the investment. And that's, I think, what we want to give to you. Carlos said it properly. We have to invest in networks. Start from the bottom. Start with stroke units. Implement intravenous treatment, thrombolytics. But on top of that, if you have the possibility, if you are there, thrombectomy as well will save lives, but especially will save burdens in families, communities, and finally it will save money as well, because that's also an important part of it. I think that is more or less the message that we want to bring here.
Yes, and I think it may be difficult for some of you who have not been in the medical field, some of you who have not seen directly when a thrombectomy has been done and the dramatic effect it has on the patient. And I think many of the panelists will say that this has been some of the most enlightening things that we have experienced in our life, really, to see these most severe strokes which can have a dramatic improvement. This is almost unbelievable, I would say, and historic. That is the first time that we are able to treat the most severe strokes. These are not in majority. It may be down on 10, 15, 20% or so, but these are the most severe, and there we can make the most benefit. And before this, we did not have an effective therapy of this proportion of patients. So what you're saying, that every patient should be examined if there is potential to give acute stroke therapies, that's for 100%. And then there are proportions who actually go down to treatment. And you've done a wonderful network job in the Netherlands, really, to develop this and increase this.
But it's possible everywhere.
It's possible everywhere.
If you invest in it, I think you can make it. One of the things I think we did not address yet, we need the awareness of policymakers, of the public, because stroke in many countries is not well recognized. Those patients stay at home, are cared by their families, so we don't see them that much. But they are there, and they are a burden. And that's, I think, that we need to show.
Absolutely. This is one of the hallmarks of the World Stroke campaign that we are driving for many years. And it's surprising that it takes year after year after year after year, and still patients don't come to hospital early enough, despite more than 10 years of advocacy in this field. So it's not time to stop with this, not yet. Okay, we will proceed with you, Carla. And we know that there are many differences around the world in access to stroke care. Can you tell me a little about your thoughts on that, and how big are the differences? What can be made of this, and how shall we look upon this, that there are so huge inequalities in stroke care? Carla.
Yeah. So thank you for the question, and thank you everybody for this amazing panel. I think there is a couple of things in this question. First of all, there is probably a lot of physicians here in the room, and I always get one question: why did you left medical practice and join the industry? And I always give the same answer, because in the medical practice, I was able to touch maybe 10, 20 patients on a day, and as part of the medical industry, this power amplify, and that's the reason why we're here. I think, as all my colleagues mentioned, this is possible, and this is possible everywhere. I'm fortunate enough to be born and raised in Brazil. Met Sheila a long time ago, where we were really starting a program, right? She was pushing for that. Had a chance to work with many countries in Latin America as part of my background. Lived in the US for 10 years, and 3 weeks ago I moved to the Netherlands. So I'm seeing that personally. And as we mentioned, I think the industry has a huge role to play in developing technology that enable physicians to diagnose, to make sure that we can go with early intervention, with the right level of support, and it works. I think it's well proven. But more important than that, as we mentioned here, there's plenty of data to prove cost effectiveness in a mid to long term. And more than that, we would love to see more stasis in the room, right? I think that's why we're all here for. But we need to think that that disparity is not only geographical, right? My daughter lives in Brazil. My mom lives in Brazil. My other daughter lives in the US, and now we are living in the Netherlands. And even though we not necessarily have the same access, if we even think about some countries like we heard about UK from Angelique, if you are in London, you have 10% of those patients being treated with endovenous thrombectomy. If you are in a rural area, it can go from 0 to 3%. So this is a challenge everywhere, and requires a lot more than technology. It requires us being in the room with the right intention, with the right connection, pushing for awareness to make sure that those patients are showing up at the hospital as soon as possible. The triage is there, the diagnostic is there, and the right treatment is offered for those patients. So it can be done. I've seen in different geographies, but requires a lot of effort, a lot of partnership, a lot of work. So, but this is really a big milestone, and if we collectively push for this, this is going to be a big success.
Oh, thank you, Carla. And I think this is one of the big concerns we have in the stroke field, these enormous inequalities that we see in different parts of the world with patients that could be treated, patients that could benefit from treatment but do not get it. I think it's one of the hardest things to see, really. And sometimes when we see curves that things are getting better, things are improving, we say that, yes, this is wonderful, we see that it is becoming better. There is also a tragedy in this type of curves, is that why is there such a slope? Why is this so slow to develop? It's a tragedy, actually, that why didn't it go up much, much more rapid than it could have been. So thank you very much for all the insights. And let's give an applause now to this panel, because we are changing panels. So thank you. We can change. And I welcome up to the podium now our representatives from the ministries. And the first, Christopher Tufton, Minister of Health and Wellness from Jamaica. Please, you can take the first chair next to me here. And Mary Munive, Second Vice President and Minister of Health from Costa Rica. And do we have here also Jaime Hernan Urago from Colombia? Okay. Possibly latecomer. We know that things can happen of these days, really. And last but not least, Dr. Darmo Reggio from Indonesia. Please come up to the stage and we welcome you. And first of all, a big thanks for taking your time to come here and discuss this important topic with you, because we can speak with this from a scientific point of view. We can give you all the scientific arguments, but without the support of you from the ministers, from the decision makers, we cannot come anywhere. So I will ask each of you to give a presentation on what is the current status of stroke care in your country. What are the main problems? And the second question is, what are your plans for the future? How do you foresee that there can be a change in your country? So I give the word first to you, Mr. Clifton.
Okay, thank you.
Thank you.
Thank you very much, Chair, and thanks to for inviting me to this event, and best regards to all who are present. Jamaica does have a real challenge as it relates to strokes, and some of the experts who identified causes and why I say similar to us. In our case, as a small island developing state, the challenge around access is a real one, because priorities, budgetary allocation is also one that requires, trying to address all the current issues. Stroke accounts for about 20% of our deaths. We lose about 18 to 20,000 Jamaicans each year. It's a 3 million country population. We have 325 health centers or community centers and 24 hospitals. And we try to respond based on the infrastructure that we have. But there are a couple of points I want to raise. Firstly, prevention is a major, major issue. How do you create awareness around the risk factors? And then, of course, through awareness, generate a response for a treatment regime. Too many of our people, certainly in the case of Jamaica, move around each day with hypertension, with diabetes, which are major contributors to stroke, and are either unaware in the first instance or do not seek out treatment And so part of the challenge, I think, is really a much more activist role by the state and collaborators, including persons here and your organization, to make some of this information available, both at the macro level but also at the micro level, and to do so in a way that is engaging almost on a one-on-one basis with persons, with families, with communities, with key influencers about why persons need to, as we call it, know your numbers in the case of hypertension, in the case of blood sugar level, because those are the key contributing factors, certainly in the case of Jamaica. We have implemented programs to do that, and I can speak to that later on if necessary, and are making some progress in that we take that message into the community through our primary healthcare system, which is now undergoing significant reform, where we are engaging more experts, more doctors, more nurses, specially trained for that kind of intervention of public awareness and screening in the first instance. The second is the treatment, which was discussed here extensively. And it is a fact that access to treatment is somewhat ad hoc, because in the case of stroke, as you know, their best result is for early determination and treatment. And within that period of time, if you don't have the facility in the first instance to do the analysis, and then of course the technical expertise to treat, it becomes a challenge. Countries like ours continue to struggle with having that expertise and that diagnostic infrastructure or ecosystem. Again, we train a lot, but we are also major suppliers of technical expertise to the developed markets. Jamaican nurses and doctors are favored by North Americans or North American institutions, and I'm being very diplomatic, even with the impact it is having on our population. And I think part of the lobbying, part of the activism has to be, how do we confront this issue in a way where we understand the hardships that are created through migration of critical healthcare workers. And COVID has taught us that we rise or fall together. And we are big advocates for a joint approach to greater levels of collaboration around training. And I'm putting it out here because Jamaica is open for any collaboration that can go into our critical healthcare system to embed experts of one form or another, to expand on treatment regime, as was spoken of earlier. We are available because we need that kind of collaboration and support to create our own capacity locally. Now, what are we doing on that? And I'll close in 30 seconds, although I know that you don't have a speaker, so I'll take his or her time.
No rush. Yes. Okay. We listen with much interest.
We are re-engineering our healthcare system, and COVID has been a big opportunity for us, and I think for the world, in that health, for probably the first time in many, many years, has gotten more priority. If not for any other reason, but just out of a sheer sense of survival. And if we're smart, we use those resources that we would not have had access to before to improve our infrastructure. And so we're building out a lot of health centers and hospitals, improvements. We're now getting into leasing of equipment as opposed to purchasing, because the maintenance, it's one thing to have a CT scan, it's quite another thing to service it and make sure it works. And in the context of lack of capacity, meaning human capacity, I've had cases, Chair, where a CT scan was broke down in one of our main hospitals, and I was told that the part had to be ordered, manufactured, and then transported from Germany. So we were waiting for a little while. And in the meantime, we had a lot of stroke victims who would need the support of that CT scan. So the logistics of not just putting that infrastructure in place, but maintaining it and ensure that it works is also a real issue. So we are now into leasing. And so whoever sells us these equipment will have to put a servicing arrangement in place. So it's an extended service. We just bought some digital X-ray machines and have on order some CT scans, which has to come with a 5-year service warranty, and within a particular period of time. We have also put in place within our hospital system these service level agreements generally across the board as a standard procedure as opposed to ad hoc purchasing, and that we believe will assist. The other is medication. We have the National Health Fund, and we are now attempting to ensure that on our VEN list, we have all the medications that are necessary, including the more modern approaches to treatment, because we think this is very important. And then in terms of rehabilitation of your limbs, movement, we have created new permanent posts. But again, to attract these persons, we have to train them and retain them. And we announced, I did in my last sectoral, and this is the final point, a major scholarship fund over the next 5 years for each year, where we have defined areas of expertise. We're offering free training, meaning government-supported training, on condition that they are bonded to work in the public health system for a period of time. And that training could also include collaboration with institutions outside of Jamaica, because more often than not, the expertise has to be trained outside of Jamaica. So in all, we see perhaps just over 7,000 stroke victims each year, certainly in 2021. Of the 7,400 or so, 2,400 died, and then the rest were a burden on themselves, their families, and of course on society. That leads to all sorts of other issues, social cases in the hospitals. The Public Health Act says if you're admitted, and even if you're released and you decide not to leave, then the hospital becomes a permanent home. And we do have that issue. So the holding up of beds, because families just don't know how to treat with persons who are disabled because of a stroke. And so part of that is the outreach through the primary healthcare system. I'll stop there, but just to conclude that it is a problem, and it's a problem that requires collaboration, and we're open for that. Thank you.
Thank you very much. And sharing your very long experience and expertise in this field. You've been so long in this field, and we're also all grateful of the initiative that was once taken from the Caribbean region when it comes to the NCDs. Overall, why actually we are here today and having a meeting on this topic is very much that you were one of those who really started the ball, and we see the progress. You touched on many of the challenges which we see and share in many other countries. I think what you say with primary care and prevention is extremely important. Without that component, it will not be effective, because prevention is so extremely important. Concerned to hear about the lack of resources going to other countries. I think is a real problem that need to tackle, and your innovative ideas. Thank you very much. So we move on to the next speaker, and to Costa Rica. So welcome. What will you say from your country perspective?
Thank you. And first, I apologize because I have a little confused. I prepared a presentation in Spanish.
Yes.
But don't worry, Dr. Molina is here. Okay?
Yes. So please come to the microphone and share it.
It's a good example of collaboration.
Yeah,
between
thank
the
you so
administration
much.
and the healthcare
And you
provider.
heard me in Spanish because you heard my beautiful language, okay? Bueno,
Beautiful, actually.
para empezar, en Costa Rica tenemos una población de 5.200.000 habitantes, de los cuales el 10% es adulto mayor. Y se pretende que para el 2050 sea el 20%. Imagínense.
Yeah, in Costa Rica, they have a population of over 5 million people. So 10% are older people. And the expectations for 2050 is growing dramatically.
Y ustedes recordarán que Costa Rica también tiene una zona azul, quiere decir que nuestra expectativa de vida es más allá de los 80 años. Por ello, la calidad de vida de envejecimiento es muy importante y obviamente lo que es el stroke es una complicación que no deseamos.
They are in this blue zone. It means that they have a life expectancy higher than 80 years old. Next slide.
Please put the presentation. I can't. Okay. Yeah. Este es un diagrama de dispersión y se ve claramente cómo hay los dos polos de las enfermedades. Sobrepeso y obesidad como causante del 60% de las enfermedades en mi país y la gran complicación, la enfermedad cerebrovascular.
So the main problem that they have, as you can see in this graph, is overweight and obesity. So actually, what's the proportion?
60%.
60% of the population suffer of 60% of obese patients, they will suffer a stroke, and they have these numbers, and these numbers will grow over the next years.
Si combatimos el sobrepeso y la obesidad, arrasamos con el 60% de todas estas patologías, evitando, por ende, la enfermedad cerebrovascular. Por eso es tan importante que en la política pública incidamos en la prevención.
So they are very focused on primary prevention, focused on these two conditions, obesity and overweight, and also hypertension. That is the main burden and the main cause of a stroke, and they just focus on these two conditions.
La mortalidad es alta cuando se alcanza y sobre todo en mayores de 75 años. Por ende, siempre la prevención, tanto primaria, secundaria como terciaria, es en lo que se va a incidir.
And they have this target of older than 65 years old, just to optimize the resources to get this target of reducing mortality and morbidity related to stroke.
Parte de los principales factores de riesgo son muchos de los que mencionaron ustedes en la primera parte, pero la hipertensión, la diabetes y la dislipidemia creo que es mucho de las enfermedades crónicas no transmisibles que fueron completamente olvidadas durante la pandemia y ahora tenemos que retomar el control de las mismas.
So you can see here the traditional risk factors, especially hypertension, dyslipidemia, that was long forgotten before the pandemic, and now they restart programs right after COVID pandemic.
Y la obesidad y el sedentarismo no pueden quedar atrás, así como el tabaquismo, el vapeo y otro tipo de sustancias que desafortunadamente cada vez van más en alta incidencia y prevalencia. Por esto, nuevamente, la atención primaria y la prevención de este tipo de prácticas es importante.
So that's why it's so important to establish some prevention strategies, not only for the traditional risk factor, but novel risk factors, also vaping, not only the traditional smoking, but also vaping. They are focused on this population. This is affecting the young people.
Por eso, desde la visión del Ministerio de Salud, uno lo que tiene que generar es no solamente dirigir y conducir a las diferentes instituciones del Estado para que puedan estandarizar procesos activos de manejo de los mismos, sino también lo que es regular los servicios de salud, para que no tengamos una atención adecuada en un lado, pero que por otro lado, en otra área, no tenga ninguna atención justamente en las complicaciones o en el abordaje de estas enfermedades.
So this is the program, the Costa Rica Stroke Program. As you can see, these three phases. So they are focused on these institutional sectors and different actors of the ecosystem, how they organize, they perform an active monitoring of a stroke, the risk factors, and also the incidence of a stroke, and also they work in the regulation of the service and policies that can be put in place over the next years.
Por ejemplo, la Política Nacional de Deporte, los planes de acción para enfermedades crónicas no transmisibles, lo que es la estrategia de abordaje de estas enfermedades, y justo el viernes pasado hicimos el lanzamiento de la Política Nacional de Salud, que como eje, uno de los ejes principales tiene lo que es la promoción de la salud y por ende evitar todos estos factores de riesgo que conllevan a la enfermedad cerebrovascular.
They have a long list of primary prevention strategies, including sport, of course, good, and also action plans. They have a dedicated action plan for stroke, and also they work in the national policy for health policy, and one of the main topics is stroke, non-communicating diseases, including stroke.
Importante, y creo que lo mencionaban, cómo socializamos a todas las personas, diferentes estrategias, como las llamen en los diferentes países. En nuestro país se llama camaleón. Camaleón porque es lo que es la debilidad de manos o de miembros, lo que es la cara, ¿verdad? Alguna asimetría, el lenguaje, ¿verdad? Problemas a la hora de la pronunciación. Y si usted tiene alguno de estos, llame inmediatamente al 911.
I love that. They have their own acronym. It's like fast. We have rapid in Spain. So they have chameleon. So it's a very popular animal.
Lo más frecuente, yeah.
The more frequent that we have,
more frequently.
like dogs, they have chameleons. So, yeah, and this acronym helps the face and the arm and the speech, and it's important for dissemination in the schools, en los colegios también.
Se intenta dar en todo atención primaria y se pretende regular para que todos puedan responder ante alguna anomalía.
In primary prevention, and they try to get the feedback from the population how they respond or the level of response of this campaign. Nice.
Tenemos un sistema de salud fuerte, tal vez ustedes lo han escuchado, que es, digamos que da una cobertura a todo el país con 29 hospitales, de los cuales 3 son de alta complejidad, pero obviamente se empieza desde las áreas de salud, que son lo periférico, y la puerta de entrada de las personas de la comunidad para poder atender desde la prevención primaria. Y conforme van avanzando cada uno de los escalafones hasta la alta complejidad para poder tener la capacidad de tener la resolutividad para un evento cerebrovascular.
So this is the map of the coverage of the service organization in Costa Rica in different regions. So for level of complexity, so the primary prevention strategies are deployed that way, and also they have comprehensive centers for the more complex cases. And when did you start? ¿Cuándo empezasteis con este programa?
Esa es la estructura de la atención de la seguridad social existente en el país, y ahí está inmerso todo el programa.
This is the current structure, and is where is immersed is embedded the program, the stroke program. Also is contemplated in this map, in this structure.
La meta es que justamente podamos tener esta resolutividad ya cuando venga la complejidad en los 3 hospitales principales, porque en este momento solo lo tenemos al 100% en uno y bastante avanzado en el segundo.
Okay, the goal is to have this level of responsiveness. So in 3 major hospitals, for now they have just in 1 hospital, I think it's in Costa Rica, in the main city, and in other cities as well. And you have to también tenéis que organizar la estructura.
Estandarizar el proceso.
Estandarizar el proceso. They need this sort of standardization.
Y es parte de las líneas de trabajo del Ministerio de Salud. Muchísimas gracias.
The main line of research and work of the Ministry of Health. Thank you.
So thank you for wonderful collaboration, and thank you for sharing your insights from your country. There were 2 things that actually I had paid attention to, and one was that you said that you had a national plan. And we think today that this is one of the key elements really to have a successful implementation in the country, is to have a national plan within each country. It's one of the major things that leads to success, and I'm very pleased to hear that you have that. And also that you have good data from your country. Is another aspect that you need to have surveillance, you need to have monitoring what is going on, what is happening. We can follow, we can see the progress. So very interesting to hear. So thank you. So we move on to our next honored guest here from Indonesia. So I give the word to you, and it's the same question that give us a brief report from what is the situation in your country. What are the problems, the barriers, and what are your plans? How are you looking forward? So, warmly welcome.
Okay, thank you, Professor Bo. Yeah. Good evening. As the other country in the world, maybe especially in development country, the first cause of death in Indonesia, cardiovascular attack. And we have difficulties to send the cure of the people when they suffer from cerebrovascular attack, because my country is very wide. I have 16,000 islands. I have 16,000 islands. I have 700 language. Yeah. Yeah. Therefore, we get difficulties more than you, maybe. Yeah. Yeah. But I have innovation, telemedicine, to practice the we call pre-hospital care, ongoing assessment and treatment, on arrival assessment and treatment, especially in the ischemic CVA. But if bleeding CVA, I cannot. And lack of number of neuro intervention, neurology intervention in Indonesia. I have, if we found the ischemic neurovascular attack, we use like atplasa, thrombolytic agent. But if a delay, yeah, I can. Maybe because very few neurological intervention in Indonesia can mechanical thrombolytic. Yeah, maybe we send our neurologist to fellow maybe in your country, maybe somebody help, maybe you. Yeah, yeah. Because I'm a president director in top referral hospital in Indonesia. Yeah, maybe you have a TKPT, yeah. Now, therefore, yeah, I have innovation telemedicine, by telemedicine, preventive activity and corrective activity, preventive, promotive, primary care, healthcare, and referral healthcare, united united by technology information system. Yeah, yeah, just like that in my country. Yeah. Okay, thank you.
Well, thank you very much. And I think from what you say, it's very obvious that we can have global or international guidelines, regional guidelines who can give some directions, but the solutions, it needs to be in the individual countries. Each country is different, and you have 16,000 islands. I cannot imagine how can you do this. You mentioned telemedicine, and I think this is another really important thing, that telemedicine perfect, of course, to make it available, really. So thank you very much for sharing your experiences, and we've been informed that there may be also people here in the audience from other ministries. If that is the case, you're welcome to have a microphone and share some of the experiences from your country. If you are not here, if you want to think about it a little, we will proceed with the program. But let me say then at this stage that thank you to our panelists. We are very grateful that you could come here, and it demonstrates also the importance that you are really doing the job. We can give some recommendations, give some background, but it is up to you to do the job and to deliver in collaboration with us others. So a big applause for our panelists, and we will proceed. And we will proceed now with our president of the World Stroke Organization, Professor Sheila Martins from Brazil, who has been an extremely active president. She has been traveling around the world. She has been seeing more places than you could ever imagine, doing advocacy and supporting stroke. And Sheila, you had a very tough journey. We know the last day you look still happy and with a big smile. So you will share the experience now. What does the World Stroke Organization do? How is the perspective of what this organization does? Sheila.
Thank you. I need the control. So can you put my slides, please? Welcome, everyone. I'm so happy to have all of you here to discuss this very important topic, and thank you for the ministers and the representatives that came here to share the experience, and the idea is really to work together with you. I went to Indonesia one month ago, and I visited your hospital. Wonderful, yes, and I'm trying to collaborate with them, but it's a huge and ambitious program that the country is planning, and I'm sure that you have a success and show to the world how to implement with this challenge that is too many islands, but I think you can do it. So, well, I just want to show a little bit what we are doing. So we have national awareness campaign together with the World Stroke Day in October that you unify our voices in the world to talk about the stroke, about prevention, about acute care, and about rehabilitation and life after the stroke. So this is very important to aware the population. We have guidelines, we have young health professionals that you train in the Future Leaders program to be leaders and to implement stroke care worldwide in their countries. And we launched 2 years ago the implementation task force. We already know what needs to be done. So we need to join our efforts to implement what we already know. So we have to start an online roadmap free that every hospital, every society, every Ministry of Health can use to evaluate the situation of the hospitals. So with this, you can see if the hospital is a minimal hospital without hyperfusion therapy, is a essential hospital with thrombolysis, or if advanced hospital with thrombectomy. And here you can see what needs to be implemented, because sometimes people implement thrombolysis and think that it's done. It's not. You have a lot of other very important things, and if you don't measure what you are doing, you cannot know if you are doing well. So it's very important to monitor also your program. So the roadmap can help you on this, and we have expert advice to help in the implementation of stroke services, implementation of the stroke network. We are working in city level, state level, or national level. Here we were with the Colombian Ministry of Health, and unfortunately he sent a message he could not come. We are working with Colombia to plan the national plan for stroke, to help them with the certification of services, and to organize there a meeting that is Global Stroke Alliance this year, so we can help with our expertise on how to implement, giving advice, because you saw a lot during all this time, and we saw a lot of examples that can fit in different countries. Also, we are helping the implementation of telemedicine that you can use easy way in our hands to see in real-time neuroimaging and advise the doctors to do thrombolysis, for example, when they are starting. Here is an example of Ethiopia. where we create a telestroke without borders with doctors from different parts of the world giving advice in real time for thrombolysis in Ethiopia. And this is a very good example of implementation because we help them to create the teams, to organize the hospitals. We got a donation for the thrombolytic drug. We send to them, we train them, and we give advice through telemedicine to help them to start. So this is a model for low-income countries. We hope you can have more help to continue. In other African countries, we are working now with Tanzania, and we need to thank a lot Angel's Initiative, Beringer Ingelheim, and also ALM that joined this program that is so important to improve and to implement stroke care in Africa. Well, we saw that some hospitals are increasing a lot, the stroke centers across the world, but they are partially implemented. The recommendations are partially implemented. So we create a certification program, certification of stroke centers, that start with an online platform where the hospital can use the roadmap to see the situation, but also the criteria for certification. And after, they can formally apply to receive a visit for certification. We have already several hospitals in different parts of the world. I will show you a little bit later. Also, we have a strong platform for education, virtual or in person, that includes acute stroke care, pre-hospital rehabilitation, and also neurointervention. And we created a few years ago the Global Stroke Alliance, that the ministers here already participate, that put together the Minister of Health, health managers, decision makers, together with specialists to discuss the situation in each country, the gaps, potential solutions, and to work together to plan, to organize, to coordinate national plans for stroke. It started in Latin America, but now we have here last year in India, and you can see this year in Istanbul and Colombia. The certification of stroke center started in Latin America. We have now 81 centers certified in 9 countries. You can see the distribution here. You can see the distribution here. And also now we expand to other regions. We start in India, in Middle East, in Egypt and Turkey, and we start the visits in Indonesia and Malaysia 1 month ago. We did the first visits there too. Half of hospitals are public, half are private, and half advanced and half essential. And we have more than 600 that already test to see if they can be certified. So it's a huge work, and we have people from different parts of the world helping us with this certification, and we work together with stroke societies or together with the Ministry of Health of the countries. We have a global stroke advocacy landscape here that we can see we are working a lot together with World Health Organization. In very important work is the framework for acute coronary syndrome and stroke that we hope we can launch this year, advising the Ministry of Health what needs to be implemented for acute care of stroke and acute coronary disease. Mia participated in African NCD strategy, PEN Plus, in Tanzania last month. We are here today when we hope you can launch the policy brief on acute stroke you receive. We will have 2 global stroke alliances, and we are all preparing this for the next year. That will be the non-communicable disease year in the United Nations. We invite you for our both Global Stroke Alliance this year in Istanbul to join countries in Middle East and also neighbor countries from Istanbul, Azerbaijan, Kazakhstan, and Uzbekistan, and in Colombia to join Latin American and Caribbean countries, once again to review the commitments and to continue improvement in the region. And to finish, we are so sorry that you don't have representatives from the Ministry of Health of Brazil here, but I think it's a very good example on how to implement from the basics to the high level of stroke care with universal health coverage and working together, specialists and governments, and with the help of World Stroke Organization. So I will show you our example here.
Where is the moment we needed the most? You kick up the leaves and the magic is lost. And tell me your blue skies fade to gray, and tell me your passion's gone away, and I don't need no carrying on. You stand in the line just to hit a new low. You're faking a smile with the coffee to go. And tell me your life's been way offline. You fall into pieces every time, and I don't need no carrying on. 'Cause you had a bad day, you're taking one down. You sing a sad song just to turn it around. You say you don't know, you tell me don't lie. You're working a smile and you go for a ride. You had a bad day, the camera don't lie. You're coming back down and you really don't mind. You had a bad day. You had a bad day. Well, you need a blue sky holiday. The point is they laugh at what you say, and I don't need no carrying on. You had a bad day, you're taking one down. You sing a sad song just to turn it around. You say you don't know, you tell me don't lie. You're working a smile and you go for a ride. You had a bad day, the camera don't lie. You're coming back down and you really don't mind. You had a bad day. Sometimes the system goes on the blink and the whole thing it turns out wrong. You might not make it back and you know that you could be well, that's wrong, and I'm not wrong. So where was the passion when you needed the most? Oh, you and I, you kick up the leaves and the magic is lost. 'Cause you had a bad day, you're taking one down. You sing a sad song just to turn it around. You say you don't know, you tell me don't lie. You're working a smile and you go for a ride. You had a bad day, you see what you like, and how does it feel? One more time, you had a bad day. You had a bad day. Had a bad day. You had a bad day. Well, you need a blue sky holiday. The point is they laugh at what you say, and I don't need no carrying on. You had a bad day.
Thank you very much.
So thank you so much, Sheila. I think the day has only 24 hours, but I think Sheila has a couple of more hours on her day. Hard work over many years, and it's one of the themes when we are speaking of stroke, that what is needed, One thing is leadership, very strong leadership, and we have seen this repeatedly, that without a strong leadership we don't come anywhere. Without a strong collaboration with the ministries who are to execute the job in collaboration, we will come nowhere. And we're happy that you are participating here, and your leadership is very, very important for us, really. So the scene, as you have heard here tonight, is really changing. Looking back, when I started, that was 50 years ago, really, when I had my first job at the Department of Neurology, there was nothing that could be done as stroke, not at all. There were no acute therapy. We were even very convinced that there will never be one, because the brain have only a couple of minutes to be saved. We will never, ever have this opportunity. And now we know we were wrong. It's absolutely, we've seen this dramatic change. We've seen so many experiences over these years. We have seen the possibilities of prevention. We have one motto from the World Stroke Organization that is cut stroke in half. Is that possible? Yes, it is possible. We need to cut stroke in half to counterbalance the increase in the populations and the aging of the populations. We need to cut stroke to have the health system to survive in terms of absolute numbers. That's absolutely important. And we will know that we will get there. There is even some countries who have seen this, and I'm speaking of my own country, that over 20 years of time, we have seen a cut stroke in half, really. We have the secondary prevention, which will reduce burden of stroke by 1/4. We have the new acute therapies, which will have a profound effect. And we have both intravenous thrombolytic therapy, and we have the thrombectomy, which we have the full spectrum, really. So looking back at 2011, this was discussed the other day. What has changed since then? Well, it's a different world. One of the diseases that has made most advances over this period is undoubtedly stroke. And I'm bold to say that there is no other disease that can have the same arguments, that is preventable, is treatable, is manageable, and I would add one word to that now, that is curable. We can see that the most severe stroke can in many instances be cured, really. So this is a bigger revolution, really. So we left some space in the program for questions and answers, and you are welcome from the audience if you have a question, if you have a comment on this to any of the speakers, or just want to say a word of witness. Yes, please, you have a microphone, identify yourself, and we're happy to hear your comment.
All right. Well, good evening, and thank you for all of the excellent talks. Very inspirational. It was so great to hear from, especially Honorable Minister of Jamaica. I really enjoyed your really, I think, nuanced techniques within country. So my name is Christine Guria. I'm actually an emergency medicine physician and a clinician scientist. Kenyan by background, but I am based between Yale University and Stanford University in America. My question was, in thinking about resource settings and all the fantastic work World Stroke has done as well, how are you engaging frontline workers that are non-physician clinicians, knowing that non-physician clinicians are still, primary or frontline workers, nurses, even clinical officers. So what strategies, anyone can really comment, but what strategies do you recommend are you doing? Yeah.
Thank you very much. And we could use your services in Jamaica periodically. So should I just turn? Okay. Right. So we actually just launched a program in keeping with the primary healthcare reform called Operation Refresh. By the way, I'm not a clinician. I'm a marketer by training, lectured at the university for many years. So I like branding my programs for recall and for action. So this program takes, in keeping with your question, the community health aides, who are the most basic, maybe not be the right word. They are the front line of all frontline workers. They are the ones who are supervised by the primary healthcare nurse and doctors, and they go out into the communities, into the homes, provide health education and other basic support services. We have 2,200 of them. And the idea is to rearrange their job description. We've given them a little increase in salary, and to retrain them to deal with essential screening in the first instance. So they become the first point of contact in the community, in the homes. And the intention is to arm them with a kit to do things like hypertensive, blood pressure checks, blood sugar checks. But also they become a critical confidant, if for want of a better word, with individuals in communities. They talk to the person who is vulnerable. They encourage them to go out to the clinics to see the doctor. We're even thinking of giving them these iPads with remote contact so they can actually speak to the doctor from their homes. In cases where persons have stroke and are in the homes and family members don't know how to treat with them, they do things like, help them with basic, turning motion and medication regime and so on. So that for us is important because they also are an important source of information. So they upload their information and then the doctors, the clinicians can then decide how to proceed with those individuals. So that's one of the more basic approaches that we believe will be, we are doing now, but we're going to be improving over time. Thank you.
Excellent. And I think what we need are good examples to learn from each other is so important, really, and to also demonstrate proof of principles that it works, it's possible to do it, really. So we have time for some more questions, if there is anything. If not, yes, Sheila, you want to say something? Yeah, please.
From MT 2020, that is one of our collaborators. If you want to talk a little bit about the initiative.
Thank you very much. I appreciate the opportunity. So I'm Fawaz Al-Mufti. I'm an associate dean in New York Medical College. I recently became the global chair for mission thrombectomy, which is the work that we do actually complements very much the World Stroke Organization and what Bo, Sheila, and me and everybody here, the amazing work you guys are doing. It complements it in that it's on the tail end of this. It requires performing mechanical thrombectomy, which, as many of the audience knows at this point, is threading a catheter into the brain and opening up the blood vessel that is blocked. And this is, at this point, something that I'm definitely biased. I am a stroke neurologist, but I'm definitely biased. I personally believe that from 2015 until today, it's how energized the field became with thrombectomy that basically energized everybody else. We're like, okay, fine. So if we can do this, we can do everything else a little bit better. And my partner basically saw the opportunity when he could have done anything else, Dilip Yavagal, and he decided that he wanted to embark on this. And our goal is essentially, again, like I said, to complement what all the work that you're all doing, and with a focus on mechanical thrombectomy. It's a little bit more advanced, but we're actively training physicians all over the country. At this point, we're in almost 107 regional committees across the globe. There's a tele-observership program where people, even if they are unable to come and train, but this could be an interventional radiologist who wants to know, who knows the technique but hasn't done it on the brain, they can essentially log on and watch a thrombectomy happening live. Also similar to what you guys are doing, we have the white paper that basically translates mechanical thrombectomy in layman terms, so it's in a very simple language. So yeah, we're extremely happy with this collaboration. Very, very proud to call ourselves your partners, and yeah, looking forward to further collaboration.
Thank you very much. Well, the field, Sheila, yes?
Yeah. I'd like to ask to Jan to talk a little bit about the Angels Initiative, Jan, that is amazing force in the world to implement stroke care.
Thank you very much, Sheila. Sheila likes to put us on the spot. Excuse me, it's an absolute pleasure to be with all of you today, and great job. I think it's really important. My journey in stroke started with stroke in our family. My mother-in-law suffered a stroke and wasn't treated in my home country, South Africa. And this prompted me to start this initiative called the Angels Initiative to see if we can do something about this. Today, This is now almost 11 years later. We have now more than 10,000 hospitals in 156 countries that are working together with us. And basically what we do is we are the hands and feet of everyone here. The experts, the World Stroke Organization, the other organizations, companies that are providing tools and equipment and drugs and solutions to treat these patients, we are basically helping to implement these things on the floor. So we have what we call Angels Consultants, who are people that go into the hospitals, they help implement. So they are educating, they are helping set up protocols, they are helping optimizing the treatment, so to help people get faster, to help people actually treat more patients appropriately, to optimize the pre-notification, to optimize the communication between the pre-hospital and the in-hospital, and sometimes between people in the hospital. So that's basically what we do. I would be really interested to speak to also, for example, the minister from Jamaica. I've seen, I just had a quick look while you were speaking, we have already 10 hospitals registered in our initiative in Jamaica. And that's basically what we do. So between the governments, between the World Stroke Organization and everyone, we are partnering and working with everyone and sending people into the hospitals to actually go and help the hospitals implement to the way that we like to put it, to bridge the gap between what is known and what is done. So to make sure that what is known and all the evidence that is there is implemented. So yeah, that's what we do. We are happy to be here. We are really thankful for the invitation, and we hope for the future that you are talking about. Thanks a lot.
It's also we that thank you, because I think the Angels Initiative is one of the strongest examples we have of collaboration between the NGO, between the Stroke Society and implementation of practices. It's one of the strongest examples here that really have made a change. It's been an implementation of stroke units, improved. It's been really coming out to the benefit of patients in a way that is, I think, almost unparalleled. We are grateful for many other collaborations. We are sure that there will be very much to do, and we are also reliable upon the collaboration with the industry. Really, we have very good relations here. So I thank you for that. I thank you for the comment from our colleague from Sweden. We are collaborators. We are working together. We have the same goal. We have a little bit of a different perspective and direction, but we are working together. It's so much that needs to be done, really. So let me now thank you all. You see that there's a lot that has happened in this field. There is a lot of possibilities and opportunities, and perhaps that is the strongest message to take away from here tonight, is that this is an historical meeting actually today. We know that things can be changed. It's possible to do it. It's not that something needs to be changed. We can tell what are the solutions, and we know that it will work, and we know that it will be cost effective. So I thank the speakers, I thank the ministers again who have come here, I thank Philips for the sponsorship, I thank Boehringer also for contributions here, and thanks to you all. So you're welcome now to continue to network and speak to each other here. So I conclude this. Thanks again for Philips for the hosting here. Thank you. Yeah, I'll take a photo of the panelists, yes.